Thank you, everybody, for bearing with me. Now, Dr. Noor has very eloquently talked about and explained the pathogenesis, the causes, the classification, the biomarkers, development, and what we have currently in terms of diagnosing, management, and quote unquote treatment of endometriosis. The thing is, endometriosis is unfortunately a condition that women have to live with. The only definitive treatment is a complete pelvic clearance. But prior to that, but because this ailment is a disease of for young women in the reproductive age group, that has to be one of our last options in order to help the patient manage her pelvic pain. Now, essentially, the problem that we have with endometriosis, like I mentioned, is that it is underdiagnosed or undiagnosed actually in a large proportion of affected women, resulting in ongoing progressive symptoms with negative impacts not only on their health, their well-being, their work, them taking time off their duties, costing the economy millions of pounds and in millions of pounds, dollars, whichever countries they are in. And that can have a lot of setbacks, not just for the patient themselves, but for the people around her as well. Now, there is a delay between the symptom onset diagnosis and subsequent treatment as well. The reason being is that current standard practice and the standards that are set up rely on the primary histological diagnosis, which can be done via laparoscopy, to diagnose and say that, okay, fine, this is endometriosis. But unfortunately, laparoscopy or surgical techniques rely on the visual identification of the lesions. Now, as mentioned by Dr. Noor, that the lesion in itself can come in various shapes and sizes. It can look like your typical, dark spots on the pelvis, or it can be just a hyperemia. It can be just some whitish spots, just something that is very vague, and to the untrained eye this is not picked up. So it not just depends on the person who's doing it, it depends on the dexterity of the the surgeon doing the laparoscopy, and the areas where the biopsies have been taken from. And deep lesions unfortunately are missed, so therefore that's an issue that needs to be tackled. Now, a lot of people, unfortunately, still do not get the required management treatment for their pelvic pain. Now, in 2017, fortunately, the NICE guidance reflected a philosophical shift, rather, presenting with an empiric therapy prior to laparoscopy in the diagnosis and treatment of endometriosis, which actually is was a very positive thought process and a very good plan of management. Now, the solution, well, solution is a very positive thing actually. The way of management, I think, is what I should have written, is to use your clinical modalities or using enhanced clinical diagnostic techniques in order to pick up lesions, assess the patient, and then carrying forward with the management, which in itself is essentially management of the pain, and then going in from there forward is to excise the lesion after you've had either a multidisciplinary follow-up or management, or going ahead with a surgical plan. Now, the clinical presentation depends on not just the location, but also the extent of the disease. The symptoms of genital endometriosis may be categorized as menstrual dysfunction, ovulatory, and reproductive. Now, really briefly, menstrual dysfunction can present itself as cyclical pelvic pain, dysmenorrhea, dyspareunia, ovulatory dysfunction with anovulation, premenstrual spotting, luteal phase defects, reproductive dysfunction. Now, Prescott et al. Did a prospective cohort study, and they have picked up that there's a higher rate of infertility in women with endometriosis, and we all know that. And this is secondary to the endometriotic lesions or implants that distort the normal pelvic anatomy. So it's not per se the endometriosis, it's a sequelae of events of the inflammatory responses that follows the endometriosis that causes infertility by distorting the pelvic anatomy. Now, I think talking about endometriosis, talking about its management goes hand in hand with the pain mechanisms. I won't talk too much in detail about this because I've got my other more advanced anesthetic colleagues who will talk to you about this in much more detail than I can. But basically, just a brief gist. So there's visceral pain and then there's somatic pain. Now, the visceral pain arises from inner organs, such as the bladder, your uterus, and the rectum. I'm talking about pelvic organs. And then there's somatic pain, which is experienced where the sensory nerves located in the skin and deep tissue are triggered. Now, interestingly, why there is a delay or a dilemma with endometriosis and its management and diagnosis is the fact that the pain of endometriosis is a combination of both type of these pains. So it's really difficult, and this contributes to the complexity of treatment. Now, again, with regards to pain, there is a debate in terms of, is this neuropathic pain? Is this nociceptive in origin? What is it? Because what essentially happens is with neuropathic pain starts if there is an injury to the somatosensory nervous system. All right. And if there is no nociceptive stimulus, you can say that, yep, this particular pain fits the criteria of neuropathic. Now, if there is a stimulus, if there is a cause, if the nociceptive receptor neurons are triggered, that is where the other sort of pain or the nociceptive pain can be categorized. And the reason we categorize things is because we need to manage these sort of problems. Now, the argument, rather, for neuropathic pain is weakened by the disappearance of these symptoms when the lesions are removed. So with endometriosis, you can say, all right, fine, I'll remove these lesions and the pain will end. But interestingly, because of central sensitization, and I'll just explain it in a bit detail later on with my next slide, what happens is because of the delay in the diagnosis, because of the delay in the management, this particular sort of pain becomes neuropathic, really, because even though you've taken the trigger away, you've taken the cause away, you've done the surgery, because of central sensitization, the patients can continue to experience this pain even after the focus has been removed. And that is where the challenge lies, and that is where the problems start. And then you're essentially left with a minimal focus of management because you've tried everything, but central sensitization has already occurred. Now, as per the International Association of the Study of Pain, central sensitization has been described as the pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage, causing the activation of peripheral nociceptives or evidence for disease or lesion of the somatosensory system causing the pain. Long, winding definition, but essentially it basically means you take away the cause, but the pain is still there because of the activation of the receptors that cause the nociceptive receptors, essentially. Oops. Uh, yeah. Now, the challenge of diagnosing endometriosis, there are no pathognomic features or biomarkers. The lack of obvious lesions does not eliminate the possibility of endometriosis. And there is poor correlation between symptoms and severity or extent of the disease. Again, the Oh, sorry, I was looking at the chat box. Again, the problem is there may be a patient who will have a frozen pelvis, bowel stuck to the uterus, periureteric endometriosis and adhesions, and she may be completely fine. She may be carrying out her day-to-day activities and everything will be fine. She won't even present to you up until later on, maybe for fertility issues or whatever. But then you'll have a woman who has got some minute implants and they may have severe pain and completely be unmanageable and then resorting to an operative mode of treatment. So it's really the two extremes of the spectrum. I've just wanted to show this slide. Essentially, it is in one of the literature reviews that I had a look at, and it just tells you about the differentials, or the, sorry, not the differentials, the algorithm for clinical diagnosis. I think all of us know that a history is essential in terms of ruling out any other causes for the pelvic pain. So history, physical examination, and imaging. Now, the patient may present to you with dysmenorrhea, dyspareunia, dyschezia. These are quite classical symptoms that women with endometriosis present, but obviously we need to rule out all other causes. I'll explain things later on as well. I've got another slide for that, so I won't delve into this in too much detail. Again, review the patient history, link things. Has the patient had a laparoscopy before? Has she had some sort of imaging before? Has she got a family history? Is she generally more prone to, has she got any autoimmune disease? Generally more prone to, recurrent UTIs? Is there anything that you can pick up that might help you manage her prior to going forward for a laparoscopy? Physical examination, retroverted uterus, frozen pelvis, pelvic masses, query endometriomas. If you can pick these things up, that would be ideal, but definitely need to rule it out, and not need to rule out fibroids or your dermoid cysts. And then obviously you've got to go ahead with your imaging. So you've got your pelvic scans, you've got your transvaginal scans, you've got your MRIs. All of these are essential tools in order to manage. Now, in 2015, the NIH recognized that that endometriosis, unfortunately, or women with endometriosis, unfortunately, have quite a lot of overlapping chronic pain conditions. So they share the common immune, neural, or endocrine system. So therefore, you may have more than one cause for the pain, even pelvic pain that women present with. So, an evidence suggests that early treatment of endometriosis and associated pain may decrease the risk of chronic pain, which further supports the importance of early intervention. Now, this is my slide. I will not go into too much detail because it's a bit busy. But essentially, these are the differentials for all the conditions that the woman presents with. So obviously, rule out fibroids, rule out PIDs, rule out UTIs. Need to rule out any bowel problems, IBS, inflammatory bowel diseases, all of these things, essentially, the neuropathic problems, painful bladder syndromes, all of these things need to be ruled out, because up until you do a laparoscopy, an endometriosis essentially becomes a diagnosis of exclusion. But in people who are more prone, the diagnosis of endometriosis clinically should have a high rate of suspicion and following that management. Again, this is just more or less a repetition of the previous slide. So the clinical diagnostic methods, and these are the things that you should be looking for in your history. Apart from, so basically the patient can come in with any of these above mentioned gynecological symptoms, and also non-gynecological symptoms like PR bleeding, shoulder tip pain, hematuria, dysuria, dyschezia. Now, it is also helpful to assess pain on a visual analog score or a numerical analog score. So if a patient comes to me and I ask her directly, say, okay, fine, can you score your pain level on a scale of 1 to 10? What would be the worst? So for a patient, everything is 10. So you need to explore this in a bit more detail to say that, look, does it make you housebound? Does it settle with regular analgesia? Has it affected your quality of life? During your periods, are you not able to even eat or drink? Depending on that, you then classify where on the pain score that this woman is. Again, this is the clinic. This is a slide, and it was a one of the systematic reviews that I picked up on, which says that deep infiltrating endometriosis, can it be predicted clinically, and how feasible it is essentially for an initial diagnosis and management for women with endometriosis. So there were 10 studies, and every study in this highlights the fact that if you examine a woman, deep lesions will be picked up. There are various signs and symptoms on history as well as on clinical examination, and then you carry on forward with your management. A quick touch upon physical examination. I've mentioned it before, so I'm not going to go into too much details, but essentially, women who have got rectovaginal or nodules in the pouch of Douglas or your uterosacrals are have over a tenfold chance of having deep infiltrating endometriosis. So we need to be very, very mindful when doing speculum examinations and your bimanual examinations. Now, just a quick gist of things. So traditionally, the central tenet of diagnosis for endometriosis has focused on the identification of endometriotic lesions in the pelvis during surgical inspection. Now, I've mentioned before, surgical inspection varies from person to person depending upon the degree of training they've had and the amount of endometriosis they have seen in their practice. So therefore, what is important is that the clinical diagnostics that we do shifts the focus to the patient rather than the disease. And that is what we aim for all our patients, really. And the employing clinical diagnostic methodologies helps in doing all of this. Now, Soliman et al. Did a study, and he demonstrated a decrease in the diagnostic delay with if things are picked up clinically, and then in terms of reducing the central sensitization that occurs in these women, reducing the deep lesions that occur if we delay in terms of the fact that, oh, let's get this scan, let's do this test, or book her for a laparoscopy, which unfortunately, especially in this day and age, peri-pandemic, post-pandemic, is very difficult because we've got a massive backlog. Now, obviously, for patients, it is essential to receive that diagnosis or to receive that confirmation of endometriosis. I agree, that can only be done via laparoscopy. But if the initial treatment is started, the degree or level of the spread will be minimal or less than what it could be. So again, that is all that I think I have to talk about. If anybody's got any questions, please feel free to ask. I think there are quite a lot of questions in the chat box. Has anybody got their hands raised, Nilufer?
Can I ask you while people are thinking? Now, you have a patient who has all the classical symptoms.
Any questions, Nilufer?
Can you hear me? Can you hear me?
You touched upon biomarkers, did you not? Yeah.
Subul, can you hear me?
Yes, we can hear you, Prof.
Yeah. Can I ask a question while people are thinking? If you have a patient who has all the classic
questions.
Can you hear
Where
me?
was the biomarker question?
Can you hear me, Subul?
Yeah, I know.
Yes, we can hear you.
Yes. If you have a patient who has all the classic symptoms of endometriosis,
No,
quite
Prof,
severe.
I can't hear you, unfortunately.
You can't hear me? Can you hear me, Nilufer?
Yes, I can hear you.
Why is she not hearing?
We can hear you.
I think I need to come off this.
You unshare. Okay. Yes, Prof, we can hear you. Carry on, please.
Right. If you have a patient with all the classic symptoms of endometriosis, quite severe, and you take her for a laparoscopy, what is the chance?
No, I can't hear, Prof, unfortunately. I'll need to.
Can you tell her the question, Nilufer? What's the chance of finding endometriosis at a laparoscopy?
Yeah.
Sorry, Prof. Are you able to repeat the question? I think there was a bit of an interruption. So just for the benefit of the audience.
Can you hear me now, Subul?
She's just gone to get that sorted.
No, I'll come there. Yeah, it's fine. Sit. Give it up. Hello, Prof. Sorry, I can hear you.
Okay. If you have a patient with the classic symptoms of endometriosis, quite severe,
Yes.
and you take her for laparoscopy, what's the chance of finding endometriosis?
Chances in terms of percentages or
Yeah, what's the likelihood? Yes.
if the patient is presenting with the classical signs and symptoms, there is a very, very high likelihood that this patient will have endometriosis. What the person who's doing the laparoscopy needs to do is ensure that they are taking appropriate biopsies. So if you don't see your typical charcoal or blackened spots, then don't ignore it to say, oh no, there's nothing there, close her up. No.
Yeah,
So
yeah.
even if a lesion is a bit hyperemic, appropriate biopsies should be taken from the pelvic side walls, ovarian fossa, yeah, that is what I would
I think
recommend.
it's a very important point that having the classic symptoms of endometriosis unfortunately does not correlate with the laparoscopic findings.
No.
We'll talk about this in the laparoscopy presentation, but statistics say only 35% of women will have no endometriosis.
Yeah.
And that's the challenge of the clinical side of things. You see patients, obviously, and you say there's definitely all the features quite severe. And it can be quite frustrating and disappointing for the patients if they can't find an underlying cause. And this is why what's mentioned in the lecture about all the complex mechanism of pain is really relevant, because they need to have the right expectation.
Absolutely.
Although endometriosis is high on the list, but it's not the only factor. So I think this is a key message from your lecture.
Yeah, absolutely. Thank you, Prof. Yes.
Any more questions? Is there anything in the chat box?
So yes, Aisha, thank you for your question. In terms of saying that what endometriosis looks like, I agree. But the thing is, we've got plenty of lectures, plenty of sessions coming on. So I didn't want to repeat too much of what Prof and my fellow colleagues will talk about. Definitely, there'll be pictures that we can review, and my colleagues will be touching upon that when they do their presentation. Number of women is. So yes, this is a good question actually by Dr. Petronella in terms of women with endometriosis and the delay in diagnostic lab. Are we okay as a GP to start the combined pill, mini pill to try and adjust the symptoms? Yes, absolutely. Please do. Because that is what the NICE guidance recommends. Because you cannot leave a patient to manage her pain and just wait for a laparoscopy, because that'll take a long time happening. So all modes of hormonal contraception safely are open to the patient. So definitely, please, absolutely.
There will be a flow chart to help with that as well.
Yeah.
In my presentation later.
Yeah. How do we take biopsy without destroying the specimen with diathermy? Prof, how do you, so that is something that I have been trained by Prof. I've had my wrist slapped, but yes, so minimal diathermy, because, and that is a skill that one needs to learn. That you should ideally reduce the amount of charring to the specimen.
Yes, it will come in the future, in the next lectures as well, and slides. And, there's a major talk on laparoscopic surgery.
I think if we proceed with the next presentation.
That's a good presentation, Subul. Well done. So
thank you,
let's
Prof.
move to the next one.